Good afternoon, everyone, and welcome to today's training on substance use and co-occurring conditions among older adults. I'm Jennifer Erf with the Massachusetts Association for Mental Health, and we are delighted that you're all here today. As we begin, I'd really like to acknowledge the generous support that MAMH received from the Tufts Health Plan Foundation in the development of this curriculum. So I want to let you know this curriculum was originally designed as a 4-hour in-person training. We had a chance to pilot it with Council on Aging, and we got some really great feedback. We're excited to share it across the state. And then, of course, COVID came along, and that disrupted our plans, but also disrupted the lives of so many older adults that we serve and all of you. So before we jump into the curriculum, I really want to acknowledge what a sad and stressful time this has been for you, for all of us. We really appreciate that you have the time and the interest to join us today, especially given that there are so many competing demands for your time and attention. So thank you for being here. So this is the first time that we're doing this virtualized 2-hour curriculum. We are hoping, though, that we'll be able to share this again and again in the future. So I am really hoping that you'll take a few minutes at the end of the training to give us your feedback. We have a very short feedback survey at the end. It'll take less than a minute to complete, although we welcome more in-depth feedback as well afterward. I want to let you know that we have 100 people registered for the training today. So in order to accommodate that many people, we'll be in listen-only mode through most of the training. We realize that's hard to stay engaged, but our trainer, Karen Fortuna, has been doing a lot of these online trainings, and she's got some great strategies to help us stay engaged. But one of them, of course, is that we really encourage questions throughout and comments throughout the training. So if you look at the control panel on the right side of your screen, you'll see a pane for questions. If you have questions or comments at any time, please enter them there. They won't be seen by other people on the in this training. They'll only be seen by Karen and me and a colleague who's helping us as an organizer. But Karen then will, or I will see the comments and questions, and we'll share them with the group and respond to them then. So please use the question pane frequently throughout the training. While you're looking at the control pane, please notice also there is a tab for handouts. And in the handouts tab, you'll see the PowerPoints for today's training, as well as what we call a REACH worksheet. I encourage you to download those and print those. In particular, the REACH worksheet is just one page, but we're going to be using that later in the training to apply some of the knowledge and skills that you'll be learning. So please, at some point during the training, if you can, download, open up the REACH worksheet so it's available on your screen, or print it out so you have a hard copy. And I think that's it. Before we get started, I do want to remind you that today's training will be recorded. When the recording is available, we will send via email the recording and the materials to you as well, possibly as early as tomorrow, but certainly by early next week. So with that, I am really excited and happy to introduce our trainer, Dr. Karen Fortuna. Karen is an assistant professor in the Department of Psychiatry at the School of Medicine at Dartmouth. She holds a doctorate in social welfare and a master's degree in social work, and she completed a postdoctoral fellowship at the Centers for Health and Aging. I've been working with Karen on this curriculum for several months, and was involved with her as she did the pilot training in person for us. She is a fabulous trainer, and you are in for a treat today. So thank you for being here, and welcome, Karen.
Great. Thank you so much, Jennifer. And of course, thanks to the Tufts Health Plan Foundation for supporting this training. So just a little bit about me. But first, we want to know a little bit about you. Who are you? What is your role in working with older adults? And so as you're filling that out, about myself is that assistant professor of psychiatry at Dartmouth College. Do a lot of work with older adults in designing and testing digital therapeutics related to smartphone applications. I'm also the section editor of the Encyclopedia for Population Health for older adults. And we also have a very cool shared wisdom feature in the American Journal of Geriatric Psychiatry, where we encourage people who work with older adults and older adults themselves to share information or share their experience working in that group. I worked with CARF International in developing the first ever behavioral health standards for older adults. And, you know, before the COVID-19 crisis, we were doing presentations across the state. And now we're doing presentations really across the globe. And so this is one of which where we're going to focus in on substance use, co-occurring conditions, specifically for older adults. So let's see, the quick poll. So it looks like majority of people are outreach workers. Some folks work for Meals on Wheels. Few clinical supervisors. Also great to see some family caregivers as well who have joined us. And peer support specialist as well, which is great. A lot of my work has been with peer support specialist. There we go, great. So, you know, this is actually really timely because what's happening now with the current crisis that people are in is that a lot of individuals are increasing using substances. And also people are also experiencing increases in mental health distress as well. One of the most recent articles literally published 2 days ago saying that in the United States, people now during the current crisis, they're actually experiencing 70% of them are experiencing mental distress for the first time ever. And we're also seeing a huge increase, a 30% increase in substance use as well. So this is very, very timely. All right, just trying to move forward. If I could just have the mouse back on here.
Try again.
Got it.
Is that not moving for? Is it moving for you, Karen?
Nope. Just it will though. If you don't move the mouse, I think I can get control of it. Well, I'll ask you to go if you can move it forward just this once.
Yeah.
So within, you know, there's a large population of older adults. Thanks. If you just go forward once more and I'll go to the agenda. So there's a really large population of older adults. And in 2010, in Massachusetts, there is 800,000 older adults. And so that's people aged 65 years or older in Massachusetts. And so by 2030, it's suggested that that number is going to be 1.5 million. And listen to this too, there is not enough providers right now and not enough support providers. So I'm talking about outreach workers, I'm talking about clinical supervisors, I'm talking about caregivers, I'm talking about peer support specialists, I'm also talking about psychiatrists, nurses, social workers, and this is really to meet the needs. And so this is what this training is about. How can we meet the needs of this population and develop the expertise we need working with older adults? So for today, we're going to talk about who are older adults. And we're going to learn about substance use and co-occurring conditions specifically for older adults, and what are the risk factors and also the protective factors as well. Then Jennifer and I, we developed this model called the REACH model, which is based on an evidence-based practice, where we're going to speak to how we can help older adults, and we're going to apply that model together.
Yay.
Hey, did I do that? Okay, good, good, good. So Jennifer and I this is our first time using this platform, so we're excited when I'm able to move it forward. Okay, so the learning objectives today. So after today, in the 2 hours together, you're going to know the signs, risk factors, and protective factors of substance use in older adults, including those with mental health problems. And no, it is on the rise right now. And we're going to recognize what are the signs to know if an older adult is at risk. I'd be curious in the questions section if you were able, let me know if you're providing telehealth services or if you're still going into the home to help out older adults. Because we can speak to some of the technology things and how you can recognize those signs through technology or even telephone as well. And so in the questions, feel free to write however you're providing your services. Then we're going to examine these complex interactions between mental health, substance use, and physical health conditions that really lead us to the point where we can't make assumptions about what's going on with an individual because it could be so many different things. And that's why it's so important to understand older adults. And then we're going to support older adults in making healthy choices regarding substance use. So we're really going to focus in on how do we minimize risk. We're not here to diagnose a substance use disorder or a mental health condition or to demand abstinence of an individual. Rather, we're here to understand that these conditions are very complex. And so in that, we're not going to make assumptions, but how can we minimize conditions for an individual? All right, great. So we'll help everyone here become a more effective advocate or caregiver for older adults that we support. So just really laying the groundwork pretty quickly is that, you know, substance use is really interesting. So it could be legal or illegal, right? Right now, cigarettes are legal. Prescription drugs, that's a substance, but they're legal, right? So it could be anything. It could be cigarettes, illegal drugs, prescription drugs, inhalants, solvents. And so many people there's many purposes for this. And so it could be a purpose to help people maybe deal with some chronic health condition, but there also are risks as well. So substance use is when, or substance misuse is when use of illegal drugs or inappropriate use of legal substances. And so what happens sometimes with older adults, there's something called polypharmacy, meaning that they have a lot of different medications that they take. That's all that fancy term means. And so as people age, their risk of having a chronic health condition increases, because that's part of the normal aging process. And older adults generally will have 3 chronic health conditions at age 65. And so people may take a lot of different medications. And so what could happen is, because of all these medications people are taking, it may be an inappropriate use. And so they may be taking it at 3 p.m. when they're supposed to take it at 10 p.m. And that could be by accident. And that happens a lot, especially with people who are maybe taking lots of medications. And then a substance use condition is sometimes called substance abuse or substance use disorder. It is use or misuse of substances that are harmful for an individual. More common types include alcohol use, opioid use, and tobacco use as well. And again, those are all on the rise right now. Great. So dependency too is something that can happen to an individual where when people are dependent on something, there's actually biological changes in the human being's body where they develop a tolerance. And so maybe somebody they drink maybe 2 alcoholic beverages a day. And they develop a tolerance for that. And so, because their body is used to having that in their body. Sometimes what happens too, when people do become dependent, they have the tolerance, but then when you take that away, you may have withdrawal symptoms. And so with opioids, what happens is some of the withdrawal symptoms, people aren't taking it, even though they've taken it for a long period of time. It could lead to sweating, goosebumps, vomiting, anxiety, insomnia, or muscle pain. And know with older adults, the presentation of this withdrawal or tolerance, it actually shows very subtle symptoms in older adults. And this is because there's age-related changes to a person's metabolism. And so we actually don't notice the subtle changes as much in an older adult that you would with a younger adult. And so that's why it's really important to know the biology of normal aging with older adults. And addiction. Addiction is really marked by behavior caused by this biochemical change in the brain. So regardless of the harm that somebody may do to themselves or other, substance use becomes the one thing that they are focusing on and thinking about. And so that's when people have an addiction. And they may act irrationally. And this could be at any age for individuals. All right. So mental health refers to cognitive, behavioral, and emotional well-being. So, before the COVID-19 crisis, 1 in 5 individuals experience having mental health challenges each year. So that's about 20% of people. And that has really increased in the recent past 2 months since March in the United States and globally as well. 1 of 3 people, so 33% of people, will experience a mental health challenge at some point in their life. This could be depression, anxiety, and about 1 in 25 people experience a serious mental health condition. So by serious, that's defined as people who have an experience of schizophrenia, bipolar disorder, or persistent refractory major depressive disorder, meaning major depressive disorder that is not treatment resistant. It doesn't work well. That's about 1 in 25 of individuals. And older adults experience these things as well. Within mental health conditions, it's created through a biological, environmental, such as chronic stress, which a lot of people are experiencing now, trauma as well, and also with older adults, because they are older, and in particular to the current crisis, older adults experience life events that could cause feelings of mental health distress or even probably need for substance use, to use substances. And so that's because of life events. So older adults experience more loss than a younger individual. And so that loss could be death of a spouse, death of a friend. It could be, feelings of loneliness. And think about this now in the current crisis, the majority of individuals that are being impacted by the current crisis are older adults. And so there's a lot of grief and a lot of loss that people are experiencing, and also loneliness as well. Whoop. Sorry, trying to go back on here. And it's going forward. Okay, wait. Here we go. All right, great. So co-occurring conditions. And so this is when you have a mental health condition, also with a substance use condition at the same time. And so if you have a mental health condition, it increases your risk of having a substance use challenge. If you have a substance use challenge, it increases your risk of having a mental health condition by about 50%. So we see these things happening together a lot. And so the symptoms could actually look the same, which even makes it more difficult, right? So let's say somebody somebody is experiencing pain. An older adult is experiencing pain. Well, you know what, that pain, maybe it could be from potentially having arthritis. It could be that people are potentially feeling depressed and they're actually something called psychosomaticizing. They're saying that they feel pain. It's actually the physical result of feeling depressed. Or let's say someone's saying they feel pain, but it's actually a withdrawal symptom from actually using a substance use. And so these things can look really, really similar, right? So what do? We're going to walk us through that. Also, too, many older adults, they don't receive treatment. A lot of older adults will, because were born in an age where you can't diagnose anxiety or depression using an app, right? Which a lot of people do now. The older adults generally don't talk as much about mental health challenges or substance use challenges. It's part of their culture. And generational background. And so a lot of people don't go and receive care. In addition to that, a lot of individuals aren't trained to provide those specific services to older adults and actually figure out, is that pain substance use, or is that pain from a mental health condition, or is that pain actually arthritis? All right, cool. All right, so let's add this on top of it, right? Older adults are one of the fastest growing segments of the actual population. So people who were born between 1946 and 1964, those are the baby boomers. So people went off to war, and then everyone came home, and then they had lots of children. And so there's a huge increase in the amount of people who are aged 65 years or older. And this is interesting too. One of the fastest growing subgroups within older adults are Latino older adults as well. So that's why we see a lot of programs out there specifically for Latino older adults. So look at this graph that we have here. You see all the way on the left-hand side here in the 1900s, it is showing us how many people in the population were aged 65 years or older. And so on that long vertical chart on the left-hand side, it's saying the numbers between 0 and then 45 million. So we see in 1900s, it was about 12% or so of people aged 65 years or older. And then we see a steady increase all the way up until 2010, where we see really the doubling of the population. So there's about 43 million older adults out there. And why? Why are there more older adults? Well, the baby boomer population. Also, too, people are living longer because of advances in our medical technologies and also pharmaceuticals as well. And so that's the reason why we see this huge increase. So interesting enough that, you know, most older adults in general, they have good mental health. And so you know, really it's like, well, why does this matter? So if we look at this chart right here, this is mental health conditions by age group. So on the bottom we have age groups. We have 18 to 25 years old. We have 26 to 49 years old, and then 50 plus years old. And on the left-hand side here, we have percentages. And so we see as individuals age that there's actually less mental health conditions among this population. And so this actually happens because as individuals age, there is an increased ability for an individual to regulate their emotions. That's a part of the normal aging process. Their amygdala gets more developed over time. And through this, they are able to regulate their emotions more. And they have increases in wisdom as well. So most older adults have good mental health, but looking at this, this is actually expected to double. So mental health conditions and substance use concern are older adults. They're pretty common, and it is expected to double. And so when you have both of these conditions, within that, you're going to see increased use of ER, going to the ER, increased hospitalization, a poor quality of life for individuals, and then early death for a lot of people too. We'll see a lot more nursing home placements, and then there's also going to be higher healthcare cost for individuals overall. So it's different if somebody was younger and had a mental health condition and a substance use condition. You're not going to see as many increase in going to the ER or hospitalizations or early death or falls related to that. There will be, you know, some travesties, but not to the extent where it's pushing the healthcare system to a point where it's not able to meet the needs of older adults. And what's interesting too, so there's a few states that are out there that have really large older adult populations. So one of which is Massachusetts, of course, and then another one too. Another one as well is, people can guess, probably Florida. That's another one too, and Pennsylvania. And so there's really, really large percentages in those places. And so some of the work we've done is in Pennsylvania and both in Massachusetts too, to really help increase the population of providers here today to actually to be able to address the concerns among older adults. So some of the concerns and risks are alcohol and prescription drug misuse. These are risk factors for suicide, which again, we're seeing a real increase in that right now. Accidental medication errors among individuals, and we see that too. Remember that polypharmacy I was talking about? These are accidental errors. A lot of opioid use disorders among older adults are generally accidental because they have multiple medications, and that's where we have this interaction between medications as well. Also too, misuse about taking prescription drugs, so taking too much or not taking enough. Untreated pain, which in people with mental health conditions, we do see that quite a bit. Harmful smoking is another concern and risk behaviors. Loneliness and isolation. And alcohol misuse, of course, worsens medical conditions and can exacerbate that. And think of the COVID-19 crisis too. These are concerns and risks just in general, but add on to that the pandemic and everything that's happening to people, why we're seeing this increase in alcohol use, an increase in mental distress, an increase in people taking prescription drugs to address those mental distress, also a huge increase in loneliness and isolation for individuals. And so, you know, this is a major, major concern right now. And so, you know, within this, we want to mitigate the risks for the individuals, but we also want to honor them and offer them choice. So we can, you know, give them input on how they can make an informed choice, even though these things are causing risk for people. All right, so why do older adults use substance? Well, pain. Pain is something that is often unrecognized, and sometimes that pain could mimic so many other things, and it's really hard to like make assumptions. So we see this a lot really in men who have chronic diseases. Loneliness as well. Loneliness is something that causes people to use substances too. Past or current trauma, some things that are happening now while people are homebound and isolated. People are maybe in domestic violence situations where people are actually living with the person who's the perpetrator of domestic violence. And so there could be some current trauma related to that. Also anxiety, depression, previous substance use, and life events like we talked about before. With depression, it's more so for women than men to use substances, but these life events, look at this, death of a spouse or a friend. How many people now who are an older adult have experienced such a loss right now during the current crisis? Retirement too, some positive life events lead to increased substances as well. And then moving into a nursing home, or actually moving from any location, is something that could cause some of that. And some other factors as well, which is really interesting, which you'll find really interesting. And so some of the other factors are related to the actual system that we are in. And so multiple physicians prescribing multiple doses. And so let's say there's an older adult and they're working with a neurologist, and they're also working with a cardiologist, and then orthopedic, right? And they need all of these things for all of these chronic health conditions that they're experiencing. And unknowingly, they're going to each of them, and let's say they're each getting a prescription dose from this. The doctor says, take this, okay, I'll take it. And then take this, okay, I'll take it. But imagine if these are all the same doses of the same thing, which actually happens. These doctors or physicians in specialty care, they're not talking to one another. So older adults could be overprescribed and receive multiple doses as well. Also, small print on the packaging. So I'll show you here. So this is witch hazel. I don't know if anyone's used it, but it's good for your skin and stuff. But look at the small print label on the packaging. Sorry, it's all messed up on there. But that's really, really small to see, right? And so part of the normal aging process, your eyesight does change, right? So this small print label in there, it's hard to see. People may not know, oh, only take a half of this pill. They may not actually be able to read that. Which reminds me of the when we did this in person, Jennifer has the Claritin for allergy season. We brought that out and showed it to people, and it's super, super small to read. Also, there's problems remembering when and whether they've taken medication. Some older adults may use a smartphone app to help with that. Some caregivers may help with that as well. There's some actually really cool prescription drug pill things that have a voice on it to remind people how to do that. But sometimes people don't have any of that, and they have a pile of pills that they go to and take. And so if you are in an organization or you are working with somebody maybe through video conferencing, or you're in their home and you see a pile of medications just literally over there in the corner, not separated out, that's an indicator that you may want to check in on that for an older adult. Also, misunderstanding instructions. This could be vision, hearing, part of the normal aging process. Our hearing does change, especially, go into one day, again, a crowded restaurant, and there's a lot of individuals out there, and a lot of people are talking. It's really hard as you age to hear that one person in front of you. And so there could be some misunderstandings. Also language barriers as well. We mentioned that one of the largest groups of older adults are Latino. And so if they speak Spanish, but the doctor doesn't speak Spanish, that might be really difficult for people to understand. And think about this too. As people age, their cognition slows. That doesn't mean that they're not able to comprehend things. It just means that it takes longer for them to really grasp something. And that's a part of a normal aging process that we will all experience. And so if you're a medical doctor, a social worker, clinician, outreach worker, and you're talking about instructions for anything, and you talk pretty fast, people may have a hard time understanding those instructions because we need to go slower so everyone can absorb that. And then prescribers failing to discuss proper storage and disposal of substances. And then prescribers not discussing potential substance abuse with patients, and that does happen too, quite a bit. So there's a lot of risks out there for individuals. Great, and so there are some generational differences. And so remember how I said right now we could download any kind of app out there and diagnose ourselves with an anxiety disorder, or diagnose ourselves with depression. And we can hear Demi Lovato talking about mental health challenges on TV. That's not what the world was like years ago. So if we look at this chart here, we see that the generational differences in folks. And so here we have the greatest generation. These were the individuals who went off to war. They lived through the Great Depression. This is the group who doesn't talk about mental health as much. It's highly stigmatized. And then moving up a little bit more, we all the way up here, we see the millennials and Gen X and Gen Z. This is where we have a lot of technology and people are beginning to openly talk about mental health. And then we have the baby boomer population who lived through the 60s, who lived through Woodstock, who lived through the world where it was free, where they may not see using substances as potentially problematic. They may see it as something that's a normal part of their life. So there's all these generational differences for individuals when talking about substance use or even mental health as well. All right, so protective factors, this is really important because there are things that we can do to help protect people. And so with protective factors, we identify things that we can actually modify. Everybody here today can work with older adults or be an older adult themselves and modify these types of things in their life. And so social connectedness, feeling connected to other individuals, that's a protective factor for people. And it's a feeling of connection. You can have 100 friends in one room with you celebrating your birthday, but you may not feel connected to them. So it's almost it's a thought that people have, right? You can have thousands of friends, but that doesn't matter. It's more of a thought that people have. A sense of belonging in a community. That's something else that really helps individuals. Hope, which is amazing. A lot of the work that older adult peer support specialists do and peer support specialists who are people with a lived experience of a mental health condition or substance use challenge have experience, with that, and they actually, research suggests that they do provide hope to other individuals, also sense of belongingness and decrease in loneliness as well. And so it's very exciting work that they do. Wisdom is another thing. As people age and gain experience, wisdom is something that can help people. And there are really great interventions out there within the positive psychology realm that do address wisdom. And then a sense of purpose and meaning. Part of that could even come through now volunteerism. People are volunteering to help other people, and that's where some people can get a sense of purpose. Resiliency around change, and then also a routine. A routine can really help individuals. Some other protective factors are attending religious services, never having used alcohol or drugs before, and also being married are protective factors as well. All right, so prescription medications. And so we did talk about polypharmacy. And so older adults are more likely to have chronic health conditions. And so with substance use, some of the use and misuse of medications can actually lead to really adverse reactions. So if somebody accidentally takes 2 pills when they're supposed to take 1, that could actually lead to major problems for individuals. So it could lead to falls. It could lead to confusion and also delirium in older adults. And so you see the severity of, mixing these 2 types of medications for older adults. And because their metabolism is slower, and this is part of the normal aging process, these medicines are going to be in their body longer. So they could have more difficult effects related to falls, confusion, or delirium. And specifically for falls, what could happen is, let's say, if a 2-year-old falls, they get right back up and start running around, right? But if an older adult falls, what happens as people age is that their bones weaken, right? They lose muscle and then their bones weaken as well. And so if somebody falls as an older adult, higher likelihood of breaking a hip, and breaking a hip leads to early mortality in individuals. So a fall is much more serious. Also confusion or delirium could be much, much more serious as an older adult. Let's say somebody's confused, they leave the home, maybe they go for a drive, and people may not be able to find them later on. And so it could lead to really more serious consequences and risks from accidentally taking these medications. Great. Medications used by older adults. So more than half of adults aged 65 use at least one psychoactive medication that's linked to falls. It's like, do you take the medication to help, or is there an increased risk of falls? And so it's a hard dichotomy about, what do you do at this point? and medication used by older adults linked to falls, and the majority of which are opioids. That's what the majority of which are linked to falls in older adults. So again, the consequences, they're really, really high consequences, and that's why it's really important to working with the older adult population. And so, so these concerns could be that if an older adult falls, I mean, that this major concern, higher risk of death, higher risk of disability, higher risk of loss of independence for individuals, and so they no longer can live at home. Maybe they have to move into a nursing home. With this too, older adults are more likely to visit an emergency room if there are medication-related concerns. And visiting an emergency room or hospital now too is also adding increased risk for individuals, considering there's a lot of people out there that are with the high contagion of the COVID-19. So alcohol in aging bodies too. So this is really interesting as well. So as we age, there's physical changes that happen in our body. And so our total water within our body actually decreases. We lose our sense of thirst. It actually decreases as we age. So people will commonly become really dehydrated. And so while there is this decrease in water, there's actually an increase in fat in an individual's body. And so this leads to the fat actually absorbs alcohol and it stays in the body for a longer period of time. And so if an older adult has, you know, 1 drink or 2 drinks, it's going to stay in their body for a much longer a period of time than it would in a younger individual. And on top of that, older adults are already dehydrated because they do lose this sense of thirst for individuals. So, so these effects, they could happen more quickly for somebody, and they can also happen over a longer period of time. And this could exacerbate lots of common medical conditions. So this is interesting too. So the safe limits for drinking are actually different for older women versus older men. And so I'd be curious in, you know, the questions box if anyone knows why. So the safe drinks are different. So for an older woman, age 65 years and older, it is 1 drink per day, while for a male, it is 3 drinks per day. And so this is related to the normal aging process. There may be, older women may have more fat in their body rather than muscle. And so it actually stays in their body for a longer period of time. And so this could actually lead to individuals experiencing difficulties related to substance use and alcohol for this group. And also too, older adults may be reluctant to seek help for this. They may not see it as a problem. You know, if you're 50 years old and you drink maybe 2 drinks a day, right? And then all of a sudden you're 60 and 65 and you can no longer drink two drinks a day, like that's kind of confusing for people. So people may not see that as a problem, especially if it's not causing any, you know, problems that they're seeing in their life. So even though they're drinking the same amount as they were younger, again, they may not see it as a problem. And marijuana, which is interesting. This is our new frontier, and so especially in Massachusetts. So about over 100,000 older adults use marijuana on an average day. And this can cause anxiety, depression for people, pain, loss of appetite. There also has been some research around some of the benefits. It's really early on to really discuss those though. And most physicians aren't trained to know when it can help or when it actually strains an individual or inappropriate for an individual. And also, if you have that baby boomer population that may be more familiar with drug use, the marijuana of, you know, the Woodstock era is actually, it's not as powerful as the marijuana that people are creating today. So it's really this new frontier that we're seeing among older adults. And so if there's any questions, go ahead and type them in the question box for us. I don't see any, but if anyone has any additional ones, please just let us know. So also, let's see. So now we're going to talk about this really cool reach model. So really, this is a model that our team developed, and it's really about, you know, what do we do? How do we minimize risk for substance use and co-occurring conditions for older adults and help them remain independent? And so it starts off with, and you'll see too, there's a handout that Jennifer developed with the REACH worksheet that that actually breaks this down for us, and we're going to be doing an example of that a little bit later. And so first it starts out with resisting assumptions, and then we talk about eliciting information, and then we assess the individual for risk. Then how do we create safety? And then help. Ask for it and offer it for other individuals. So it's really interesting. We made this one first because with the resist assumptions, because with older adults, you know, we've kind of talked about this a little bit, that some of the things that manifest in that we can see by an individual, it could be so many different things, right? So a substance use problem could actually look like a mental health problem, and a mental health problem could be a physical health problem. And so we really need to resist assumptions and get more information when we work with individuals. And so it's really interesting. We've been doing these other trainings, and we've been talking about if you're doing a video conference with somebody and you're a psychologist, and psychologists really focus in on symptoms. And let's say you're doing a video conference with someone and somebody's talking really, really fast, and that's abnormal for them. It's abnormal. The first thought may be, because they're a psychologist and they have that filter, which is great, is that, oh, it's a symptom. They're being loquacious, meaning they're talking a lot. Maybe that's a symptom of bipolar disorder. But let's resist assumptions. Maybe it could be all sorts of other things. Somebody could be talking fast because potentially they're excited. They're excited that the football season's really going to start, so they're talking faster. So resist assumptions there. It could be that the individual is feeling anxious about something too. So it could be another mental health related problem. So it could be anxiety, and resist assumptions. You want to ask and elicit more information to find out what it actually is. So this is probably the coolest chart. And this doesn't include all of the complexity with older adults, but it really just shows you that, you know, working with an older adult, it's really like peeling an onion. So on the left-hand side here, we see symptoms, right? We see an older adult presenting with hallucinations. We see them presenting with sudden memory loss or confusion. We see them presenting with a fall. Well, all of these things could be totally different things. So, for example, let's look at hallucinations for the top one here on the left. So for that first column, if an older adult is presenting with hallucinations, well, it could be lots of different things related to physical health. It could be that they are dehydrated, knowing that older adults lose their sense of thirst as they age. It could be dehydration. It also could be brain cancer. It could be vision or hearing loss. That's part of the normal, natural aging process. And these ones in red, it could be in multiple columns, but it also could be Alzheimer's disease, Lewy body dementia, Parkinson's disease. Well, what about mental health? So someone's presenting with hallucinations. That could be bipolar disorder, could be someone experiencing PTSD, could also be someone experiencing schizophrenia. Finally, substance use. It could be withdrawal, illegal drug use, could be a prescription medication side effect. You see, it could be so many different things. So really, it's really important for us to address the complexity with that. And note that this list is not exhaustive. This is just to show that it is kind of like peeling an onion. So imagine if an older adult goes to a primary care office and they say, I'm seeing things that other people aren't seeing. A primary care office, they might think, oh, well, that's a physical health difficulty because that's what they're trained in. Now, what if an older adult goes to a mental health clinic, or where they will say they download an app for diagnosing some type of, they talk to a therapist, a mental health therapist, and they say, I'm seeing things that other people aren't seeing. Well, they may think it's a mental health condition. But then if an older adult goes to a place, maybe an AA meeting online, Alcohol Anonymous meeting online, Narcotics Anonymous meeting online, they say that I'm seeing things that other people aren't seeing. They may think it's a substance use problem. Interesting enough, I was actually thinking too, like if you talk to a social worker, potentially an older adult says that, my first question would be, well, what are you seeing? And maybe it's a loved one, because maybe they lost somebody recently. And sometimes people have hallucinations that they actually see people after they've lost somebody. So we all come in with these different filters, but you, as learning about older adults and gerontology, need to know it could be this major complexity of individuals. And Jennifer, I'm going to stop there and see if there's any questions that you would like for me to address. Oh, well, actually, I'll write to it. So there was one individual who wrote that they're working with an older adult and they were having hallucinations from taking a medication. That could happen as well. And then they were going to test them for dementia, and then they stopped, they switched the medication, and then the hallucinations went away. So those are the types of things that that's really important that people know. So when you are working in these organizations, whether you're in a mental health organization, substance use, physical health, community care organization, or you're in the home, you're a caregiver in the home, these are the things that you could speak to when you're talking to all types of individuals. So we know that, resist having assumptions with people, super important. Next, well, let's start eliciting information. So we really want to ask questions without judgment. We call this empathetic compassion. And so it's asking questions without judgment. Wow, Karen, you're talking really fast. What's going on today? Well, did you hear? The NFL is really going to kick off at the right time. Oh, okay. Right? And so, we want to ask questions without judgment, non-judgment. And a lot of folks, we can do this through asking open-ended types of questions. Just kind of, what I did. Oh, wow, you're talking really fast. What's going on today? So open-ended questions allow for people to expand, not saying that, Karen, are you experiencing loquaciousness? Like, what are you talking about? That's a yes or no, and using language that people may not understand. Also, we can ask questions non-verbally, or when we ask questions through non-judgment, we can ask them in a way that's very open to people. So if I were to ask an individual, let's say I'll ask Miss Elizabeth that's on here, we'll say hypothetically, and I ask her a question, how are you feeling today? Look at this nonverbal communication. Does this seem like anyone would want to talk to me? So anyway, another way I can ask Miss Elizabeth here is like, how you doing today? So those nonverbals are really, really important for people, even through technology too, and even over the telephone too. So if you're talking with people on the phone, people can hear that. So we want to elicit information and do that without judgment. So open-ended questions. And also nonverbals that you can see if you are doing some telehealth work for people. And then also too, you can ask collaterals as well. So collateral just means that you can ask individuals who is not the individual themselves. So maybe it's the person who's caregiving for them. Maybe it's a health provider, if you have permission to talk to that health provider. Maybe it's a friend or family member, again, if you have permission to talk to that individual. So elicit information, all the information that you can. And so there was an older individual I was working with, and they had fallen, right? And they're older adult, they had fallen, just totally out of the blue. So we go into the home and we apply, there's the CDC, Center for Disease Control, has a way to rearrange your home to make it safe for people to walk around the home and not fall, right? So we rearrange the home in that way because, well, we think, well, this is the first thing that needs to be done. So 2 weeks later, the individual falls again. So we ask him, what's going on? What's going on? It's like, oh, everything's just in the way. And so we move it again, right, for the individual to make it better for them. And then we find out after talking to one of their friends with their permission that the individual was actually using was increasing their alcohol intake because they had recently lost one of their close friends. And so the individual was actually drinking alcohol and was falling over things, and this was mixing with some medication. And so we really want to elicit information. Sometimes from the individual, it may not be as accurate, and so we can talk to some collaterals as well. And so these are other individuals we can talk to. And also too, read this by Miss Sarah. I had an individual who was on a variety of different psych meds that turned out to be causing hallucinations again. It turns out no one was overseeing the meds carefully, and then they just kind of added more and more meds. And so thankfully he had been hospitalized and the meds were removed and he no longer had those issues. This is time and time again. And so this is a major, major problem for individuals. Cool. All right. Scrolling forward. All right, so what are some signs of possible misuse? So anxiety. So if you are providing telehealth, right, you may be able to see some signs of anxiety. So people could be, talking fast. You could see a person maybe looking disheveled, right? Maybe they're not as hygienic as they normally are, so you can actually see those things. People will tell you too that they're not feeling well, they feel nervous. A lot of older adults won't use terms like anxiety, depression. They'll use terms that are like nervous or I'm feeling blue. Specifically within the African American community, we hear the term I'm feeling blue rather than I feel depressed. Some other signs are sleeping problems. And note too, a lot of people are having sleeping problems right now as well. As I spoke to the increased mental health distress, also increased substance use problems. Also within that, a lot of people, specifically in the United States, are having sleeping problems too. And so again, important to, to not make assumptions because it could be the physical environment that we are in now. Failing to keep up with medical appointments and treatment. And this is important too, because now a lot of people are using telehealth to access these medical appointments and treatment as well, for physical health, mental health, social health, substance use too. And a lot of people we're seeing with the increased use in telehealth that people aren't missing appointments anymore. People aren't canceling appointments anymore. So it's a huge red flag if we see that people are actually missing medical appointments, specifically right now. Also a depressed mood. And so if you meet with an individual or if you are talking to an individual with phone, because sometimes that's what we have to do now because we can't be together, you can actually hear potentially a depressed mood. And so if people talk really slow and steady in a deep tone, that could indicate depression. It could also indicate that they're bored and, they're just, so we want to resist assumptions, but that is one way that we can actually assess whether somebody may potentially be not feeling well or feeling depressed. Also with depression, you may see people, if you're video conferencing, the room's not clean around them. People are amotivated, meaning that they're not motivated to take care of themselves or the room around them. Check in on that stuff. These are some signs. Reoccurring accidents, falls, injuries, or bruises. So the individual I told you about that they kept falling within the home, we found out that it was actually alcohol use. Right now, there's an increase in domestic violence among individuals. And so older adults, their skin, as people age, our skin actually thins as we age. And, there's a lot of great things to aging too, but these are just like the biological things that happen. So if somebody, so older adults will bruise easier, really, which is what it boils down to. So note too, if you are doing video conferencing and you do see bruises, you can ask about that. And maybe if there is a domestic violence situation and somebody is in the room, they may not feel very comfortable talking about that, but note that as well. But also note too, it may be all sorts of other things because older adults have thinner skin. And so they may look like they have more bruises. Confusion, disorientation, unexplained changes in eating habits or weight loss. You'll be able to physically see this with individuals. And so it could be substance use, but maybe it's, difficulty getting to the grocery store right now as well. Problems remembering things, or new and intensified pain that people have or report to you. So other signs are isolation and increased desire to stay home, lack of interest in activities that they previously enjoyed. That's another one. Problems with hygiene, which we talked about, and you'll be able to see. Lack of concentration, and that definitely could be one, and that's also a sign of potential anxiety. But again, you're really going to want to elicit more information about that because the environment that we're living in right now is really anxiety provoking to a lot of people. Mood swings or personality changes, problems concentrating, and chronic health complaints. And many older adults, remember that greatest generation, the ones that went off to war, experienced the Great Depression, they may feel a lot of shame related to substance use, and they may try to keep their struggle a secret. And so opening up to individuals and asking those collateral, asking the people as well, is really important, like family members and friends. These older adults in this greatest generation, probably 85 years or old now, they may see it as a moral deficit. And a lot of people from that era, it was a really difficult time to live. And so, but people still struggled through it, but they didn't, at least within that generation, there was less complaints about the world around them. It was like, we need to pick up our bootstraps and move forward. And so they still have that, that's still generational thinking to them. And so that's why these collaterals are really, really important. Cool. I went forward, sorry. All right, so then, well, let's assess for risk. All right, so we're resisting assumptions. Then we're eliciting more information from the older adult and also individuals around them. We're using telehealth if we're going to, video, phone, listening in and hearing changes in people's tone and voice. And then we're going to assess the risk for the individual. And so your company, your organization you work for will have policies on reporting the risk. And so you want to really stay within those policies. But does substance use pose risk for older adults? What are those risks? So let's find out. So signs of a possible opioid overdose are being unconscious or unresponsive, shallow breathing or no breathing. And in this case, you don't want to leave the person alone and call 911 immediately. And so this is interesting too. So why older adult, right? The symptoms of shallow breathing, of, the pinpoint pupils. Because people age and their biology changes, the signs may be so subtle that you don't see them, or that you may not think that they're a problem. And so you always want to check in with an individual for these types of things. And we'll see this a lot with medication withdrawal as well. And so even these symptoms, they might be so subtle. So you can so in the physical body, they'll be subtle, but you can look for clues in their home, right? Or within the virtual environment that you are within the home. And so some clues, well, we'll go over the symptoms first. So cravings, remember, they could be subtle. Anxiety, irritability, their stomach bothers them, sleeping problems, dizziness, lack of coordination, fatigue, flu-like symptoms, and headache. And so a few things you can do. You can ask people, have you stopped taking meds? Look for clues around the individual's home. It could be, again, a pile of medication. It could be no medication in the home. You can ask people, if you're providing telehealth, well, show me what types of medication you're taking. If they don't know, or they don't know where it is, these could be subtle hints of a medication withdrawal. And so some of these things may actually require medical treatment for an individual. And in the case of COVID-19 as well, some of these actually could mimic some of those symptoms too. So we want to make sure that you are able to talk to their health care providers, or at least have those things in place so you are able to talk to the health care providers. And then, of course, create safety for the person. And so we're going to resist assumptions, that we're going to elicit more information, we're going to assess the risk of the individual, and then we're going to create safety for the individual. And so this is working collaboratively with the older adult, of course, patient, family members, friends, all sorts of referral networks if they're available. The 311 in Massachusetts, which is for specifically working for older adults and older adults in need. And we're going to minimize those risks associated with substance use. All right, encourage older adults and family members to ask their doctor related to minimizing risk for drug interaction. So encourage them to talk to their doctor. So what is the name of the medication you're taking? Why are you taking it? How should they be taking it? So Miss Brittany, Miss Sarah, Miss Elizabeth, who have all joined us on here, they all wrote to individuals taking way too many medications that were causing hallucinations. These are the types of questions that people can ask in whatever role you have to help minimize that risk. And it sounds like these eventually did come out among individuals too. And note too, older adults may store medicine as well, especially now. And so ask people, do you have a surplus of medications? And so these are just some ways to minimize risk. Here's some of the different ones. Could this medicine affect my brain function? Can I safely use this medicine with other remedies or vitamins? Do I need to be on all these medications? And these are conversations you can have, or an older adult can have, with a protective service worker, outreach worker, social worker, daughter, mother, caregiver, father. These are any questions that anybody can ask an individual. And so what we're seeing now with the COVID-19 crisis is that we're all becoming support workers for individuals that can't get access to the normal supports that they have. And so these are questions and things that everybody can do to help minimize those risks. Some things people can do, such as caregivers or older adults themselves, if they do want to use technology, which many older adults do own smartphone applications or smartphone apps, more specifically tablets. Older adults have a preference for using tablets, but there's some really cool apps out there that can help with behavioral change. And so there's these really cool pill boxes out there, some of which are talking pill boxes, which really helps people organize medication. Imagine having to take 20 medications all at different times throughout the day. That's really difficult for anybody. And so there are pill boxes that help. There's also talking pill boxes that remind you. And there's also pharmacies also offer daily packets for individuals and what they need to take for certain times. And so these are great ways to minimize risks. And this app we found on the AARP website. And in the sense that if an older adult needs a phone or needs connectivity right now, the local United Way in Massachusetts or any other place, all you have to do is dial 211 on your phone. This gets you to the United Way, which is a nonprofit organization that's offering help for individuals right now. Help for getting people phones so they can stay connected with people, helping people with housing, helping people with food, all sorts of types of things. So if you're a support worker, you can call the 211 and help them. There's also SafeLink, which is a service for people who are Medicaid reimbursable, where they'll get a free phone for individuals. And then Lifeline, which is attached to that, gives people free data plans too. So these are just some risks, minimizing medication errors and also promoting connectivity for people right now during this difficult time that people are in. And then also reducing fall risk. And so fall risk is a major issue. And so I mentioned that the CDC, they actually have a really cool walkthrough safety assessment for an environment. And so if you're not in a location where you're able to go into the older adults location, because sometimes people aren't able to do that because of the current crisis, you can print out some of these information and send it to people. People are putting flyers on in large sky rises, flyers for individual about making your home safe to minimize the risk of fall, or to even suggest, hey, there's a telephone call tonight for people who need extra support during this time, older adults. There's also some really cool programs out there that are teaching older adults how to use technology, maybe if they want to connect with people, and so that could be another one too. So what people can do is also discuss current health conditions, medications, and substance uses openly. It's okay to talk about these things, especially with that older adult older population, 85 years and older. Talking openly about it will suggest to them it's okay to talk openly about it. More the boomers will probably talk more openly about it. We do want to ask when was their last eye checkup as well. That's a way to reduce fall risk for people. And you can notice if they're walking into walls or furniture. And this is some way that you can help individuals too. You can recognize that, oh, there is a risk if people are walking into walls or they're holding onto furniture as they walk through. So people can enlist support and discuss some of the alternatives for individuals. All right, there we go. So harm reduction. So before people are ready to completely stop using a substance, they may be willing to take some smaller steps to reduce some of the harmful consequences for it. So some argue that this could enable people, and then because it doesn't allow people to hit rock bottom. So within the health behavior change scientific literature, one of the best ways for people to change their health behaviors is to hit rock bottom, which is a shame, but that is one of the best ways to do it. Another way to approach this is through the harm reductionist approach. And so when people cut down on something or reduce their harm, they actually have more motivation to change habits. And so there's multiple approaches to that. And so here we're trying to minimize risk. And next, ask for help and offer help as well. So, if you're not sure if someone has a substance use problem or you don't know how to respond, reach out to people. I'll tell you, I was at a peer-run center in New Hampshire. I was I was actually listening in on a presentation there that was really cool. And I'd gotten up and I went to the restroom, and there was 2 people in the restroom that had that were unconscious. And apparently they were taking heroin, I guess, and they were unconscious in the bathroom. And I didn't know what to do. I was in shock. Even though I give these trainings, I was in shock and I didn't know what to do. So you know what I did? I turned around and I asked for help, and to minimize the risk. And the police came, saved their lives, and it was great. And so, know when to ask for help. And it's okay to ask for help. And no one is alone in this. In that situation, you could chat with. I was there because I didn't know anyone there. I was just going to a training to be a participant. But you have supervisors. You also have family members. You have friends. And so you have your colleagues here, that you work with as well, your work colleagues too. And know too that recovery is a process, and that meaning that relapse is likely to happen. People may not feel well, and so ask for help when you need to. So when you're offering help to some people, let's see, there we go. So what are some reasons why older adults may be unable, unwilling, or resistant to get help? Well, one, remember the older adults through the greatest generation who lived through the Great Depression and World War II? Well, it's a generational effect. They may not ask for help. That was something that was part of their generation. People pulled themselves up by their bootstraps, and they took care of themselves and their family. So that's a generational effect. There also could be shame and stigma attached to an addiction or a mental health condition. You may see this even more predominant among potential groups such as African American groups that may turn more to the churches for help. Why Latino older adults will turn to their family for help. There could be a lot of stigma attached to this. Fear of losing control over their lives, shame, suspicion, and fear, financial constraints too, especially now where people are losing jobs, losing health care. There could be all sorts of stuff. Mental health issues such as paranoia, memory loss, and depression, and of course lack of information about what services are available. But there's a really cool service in Massachusetts, amazing service, right? And so this is the Network of Care Massachusetts. And Jennifer, if you don't mind just sharing with people this link so people can access it and see what is in there. And so this is a help resource for individuals that shows resources that are available related to mental health, substance use, social services. There's thousands of programs in here specifically for Massachusetts. And there's information on how to navigate the system. Oh, hello, Jennifer.
Hi. Yeah, we're really excited to share Network of Care Massachusetts. It's been available now just for a couple months. It is a resource that has more than 5,000 organizations offering mental health, substance use, and social services. There are lots of ways that you can search to find resources statewide. You can search by zip code if you're looking for services that are near you, and by search terms. So you can look for services specifically for older adults. You can look for services specific to substance use or mental health. You can look for services for food security, housing services. There's our tabs specifically for older adults and for substance use. This is an old shot, an old screenshot from the homepage, but the current homepage has a banner for COVID-19. So that will take you to a separate page with a range of resources specific to COVID-19. We have some resource lists for older adults and for substance use. And when we send the recording for this For this training, I'll be sure to include the link to Network of Care Massachusetts and also a copy of the resources for older adults in case that's helpful to anyone. But we really encourage anyone who is looking for support and services in their area or just wondering what's available across the state. We really encourage you to come and use this great free resource.
Awesome. That's great to hear. Exciting that Massachusetts has that, considering, you know, us, Massachusetts, Florida, Pennsylvania have some of the largest older adult populations. And Jennifer,
So Karen, I just realized I didn't give the address. We'll send you the link, but you can go to www.massachusetts.networkofcare.org.
very cool. And what's cool about this too, it's in English, Spanish, Portuguese, and a whole bunch of other languages too. And so that's really great, especially for our diverse population in Massachusetts. All right, so some effective evidence-based approaches. And so, and this is to help co-occurring disorders in older adults. And so there's the screening, brief intervention, referral to treatment. It's called ESPER. A lot of clinicians will use this. There's interpersonal psychotherapy as well. And so this could be related to cognitive behavioral therapy, acceptance and commitment therapy, all different types of therapies. And you know, if you are working within a network, you want this to be age appropriate. And so it will be different. You know, if you're going to refer somebody out to interpersonal psychotherapy, you want to make sure that they understand working with older adults, because older adults, again, have a unique biology, have a unique presentation of illness, right? Could be physical illness, mental health challenges, and also have an increased life events so this environment of, you know, a more loss in an individual's life, or retirement. So those types of life events impact an individual as well. And so if you are doing referrals or are going to be working with this population offering psychotherapy, you do want to be trained in geriatrics for this. Also, narrative therapy is amazing. Anybody can do this, non-licensed clinician. And so this is narrative therapy. It could be called storytelling. It could be called reminiscence therapy. It's called all sorts of different things, called life review. So this is a really great approach when you can work with an older adult and you have them share their story. And as people share their story, you work with them to rewrite it. And that allows people to reconnect with themselves and to start to make changes within themselves if they choose to make those changes. A lot of older adult peer support specialists are trained in this, and happy to share additional slides on this because it's something great that everybody can do. And that's really, really effective, especially in a time now where there's not enough healthcare providers to provide all of the mental health services that we need and all of the substance use services that we need, no matter if they're old or young. And also motivational interviewing as well. It'll help reconnect people with activities and help people work towards health behavior change as well. And I'd say peer support too is another great one. So if you're within an organization, peer support is really added on this augmentative program that helps people restore hope and build confidence. And a lot of peer supporters now are training older adults in technologies to help them get some of the services that they need. Cool. So, you know, when should you call police? Remember that time, well, moments ago, I told you that I walked into the restroom and there's two people there that had really overdosed. Well, when should you call the police? Well, personally, I didn't feel safe in that environment and I didn't know what to do. So I just reached out to the person that was around me, but you really want to prioritize your safety. And so if you feel unsafe at any time, you know, you call 911, and that's okay to do. And when the police do arrive, we suggest to let them know everything that you know about the situation, so that the police can approach the situation with the right amount of caution. And so sometimes there's crisis interventions, and police officers may not be trained to working with older adults with mental health conditions or substance use challenges, and they may respond overly aggressive when they need a more relaxed type of approach because there's nothing unsafe about the situation. So you probably, if you do call the police, let them know if the individual is violent, has been violent in the past, or if they have a weapon on them. But do call when you feel unsafe, and so be as accurate and detailed as possible. And don't exaggerate the situation to get a faster response. So Jennifer, we're to the point now where we have some great case studies. And we also have this great REACH worksheet. We wonder if there are volunteers who could read through the study and verbally fill out the worksheet with us as a team. We could unmute your microphones in doing that. And so if you download oh, go ahead, please.
So Karen, I think there's a way for people to raise their hand to volunteer if they're willing to do that with us. And I'll be able to, full disclosure to everybody, we're figuring this out. We haven't done this before, but we really want a chance to be able to collaboratively apply the skills. So, so we think there's a way for you to raise your hand, and if you do so, I'll be able to, we think, unmute you so we can participate kind of as a group in completing the worksheet. So, if you, unfortunately, we have a slightly different view, so I can't tell you exactly how to raise your hand, but I think that if you look at the control panel on the right-hand side of your screen, you'll see a little icon with a hand on it. And we promise not to put you on the spot or make it too awkward if you volunteer, but we're hoping we might get some of you to do that. Another way you can volunteer is to type your type it in the question box. Just let us know that you volunteer, and I'll be able to unmute you that way too if you don't see the raise hand function. And I know there's someone out there who wants to volunteer, a few of you. So
okay, yeah. Robin has volunteered. Thank you, Robin. And
yeah.
Miss Robin and Miss Sarah.
And Sandra. So let me see. I'm going to unclick these.
So Sandra,
Sandra?
Yep, that's me.
Hey!
Oh, awesome. Thanks so much. And I'm going to Robin, you're unmuted, but you are self-muted. So I think that you can now click your microphone so that you.
I think I got it.
There we go. Yeah, that's great. Okay, we have Robin and Sandra. And do we have any other volunteers? Is there anyone in the question box?
Yeah, Miss Sarah Fulcher.
Okay.
Sorry if I totally messed up.
No. Thank you all for your patience. We have to sort of go through to find you in the participants list.
Oh, cool.
Sarah?
She's on too.
Yep, I'm here.
That's great.
All right.
Okay.
If you go over to your handout section, there should be a REACH worksheet that you can download. And so on our right-hand side, there'll be a worksheet. And so basically, we're going to go through together as a team the case study and we're going to fill out the REACH worksheet together. And so we'll kind of talk through it for folks. So I'll read it through. I'm hearing a little bit of echo, so if you mind just muting your phone, that would be helpful. It might be, all right, cool, thanks. Awesome. All right, so is it Kowalski, Jennifer?
Mrs. Kowalski.
Mrs. Kowalski. I can do all sorts of stuff, but pronunciation is not my forte. Mrs. Kowalski's neighbor called the elder abuse hotline and said she is concerned about her welfare. She tells you that Miss Kowalski was in recovery for alcohol use for many years, but over the last week, the neighbor thinks she has been drinking again and seems unable to care for herself. This morning, she wandered outside in her pajamas, confused. The neighbor had to guide her back to the house. Miss Kowalski has an adult son who lives nearby, but the neighbor doesn't know his name or how to reach him. When you arrive at the home, you notice that the mailbox looks full and there are 3 newspapers on the driveway. Miss Kowalski answers the door, but she looks frail and disheveled. You notice a prescription bottle of oxycodone on the kitchen counter with 3 pills left in it. Oh, I gotta go back. Oops. Thank you, Jennifer. So if we applied the REACH model, so the first part of the model is resisting assumptions. So when we hear about Miss Kowalski, what are some alternative explanations for her behavior? So we have Sandra, Robin, and Sarah. Do you have any thoughts on some alternative explanations for her behavior?
It could be a UTI or something medical.
That's a good one.
It could be the onset of a cognitive impairment or dehydration, depression.
Wow. That's awesome. So let's elicit some information. So who can we talk to in this situation? How can we elicit information?
We'll talk to her first, Mrs. Kowalski.
Nice.
Probably.
I want to talk to the doctor about the oxycodone prescription. It could be something new. It could be something old. You know, people might just be assuming that she took all the pills when realistically it's the right amount that she has.
Yeah. That's great.
I'd probably talk to the neighbor who called too and see if you can get in touch with the son to see how new this behavior is or what's been seen in the past.
Yeah, that's great. That's great. All amazing. And then
Whoever, yeah, and if anybody else is, if she has a case manager or anybody else that she's connected to, certainly that would be.
right.
One of the things we haven't considered is that she could be in withdrawal, and that's something we would also want to know.
So how do we assess for risk at this point?
Determine who her informal supports are, you know, if this was something that just happened overnight or if it's slowly getting worse.
And you need to get somebody over there to do an assessment of the home, her ADLs, her IADLs, you know, what she can and can't do, because it looks like there's a number of things that she's having trouble with.
Yeah, all makes sense. And then let's see what the next one is in our REACH model. And so how do we create safety for her? I feel like we're already kind of working towards that too.
Well, certainly try to find somebody who's familiar with her, who already has a rapport, if there is such a thing, or, try to work to build that somehow, get to know her, sit and talk, find out what her story is, as you said.
I might see if nurses, visiting nurses, or home health aides to help around the home and add extra eyes during the day.
I'd also want to address, if she's taking the oxy while drinking alcohol too, and if that's something she's been doing, or that might be a result of it too.
Yeah. I would wonder if she actually is drinking.
Yeah.
So that's, maybe it's, questionings around that too, if she is drinking. It could be all sorts of, would you say it could be medication for the individual. Cool. Then let me just open up the last one. Ask for help and offer help. What would we say with that one? Let me see.
I think somebody had mentioned, working with the visiting nurses to kind of look at her medications, come out for an assessment to figure out her IADLs and her ADLs.
Yeah. And I wonder,
senior centers are good places to hit up too, to get supports for like transportation to and from appointments and meals. If she's having trouble, she can go get meals at the senior center, or Meals on Wheels if it's a nutritional thing or whatever.
it's great. Yeah, that
And
sounds
it sounds like protective services will probably need to get involved to do the initial, assessment and go over there and figure out what is going on, if they call the elder abuse hotline.
And I wonder too, like maybe that network of care, maybe there's something in there that there's more programs and organizations, or maybe there's treatment for alcohol use difficulties or challenges, or at least screening for that might be something as well. Oh, cool.
Well, also, if she's been in recovery, she may already be connected to a recovery community, and then there's also the peer specialist. That might be something for her that she might, that might be helpful, but that's down the line after you figure out what it is. So.
That's great. Cool. Well done. Well done. So we have the really cool Reach worksheet that it just helps people go through. And you guys, Miss Sandra, Robin, and Sarah, amazing job. Well done. Well done. So very cool. So at this point, do you have any questions for us? People could raise their hand. Some people are already unmuted, so you could just speak up. But if there's any questions for us, we're here and we're happy to answer some of those questions. And actually, I'd be curious if Robin, Sarah, and Sandra, have you been providing? Are people going into homes right now for older adults, or what are you seeing right now as the most challenging thing for older adults?
I'm actually a protective worker, and we are asked not to do any in-home visits unless it's an absolute emergency. And I think that is the biggest struggle right now, because we're talking to the elders over the phone and we're getting that input, but we're not seeing in person how they're appearing, what the condition of the home is. And obviously it's easy to lie to somebody over the phone, but when you're there in front of them, you can pick up on different things.
And these are telephone calls for folks?
Yep, because a lot of them don't know how to access technology, of course. So we can't do the video conferencing, so it's all just through the telephone.
So some options are, get them access to technology through a 211. And then there's free trainings right now. If you go to the Aging Resource Center at Dartmouth Hitchcock, they have free trainings now on how to use technologies, how to use Zoom, how to connect with people. peer support specialists around the state too are also training people. And so that's one way to get kind of more access into the home, because hearing things is, you know, seeing people, you can see a lot more with folks. Just a few options. I heard in Massachusetts that the calls are down right now, which is kind of, you know, scary.
Yeah, they are. Because people aren't being seen by anybody. And it's a good thing, so there's not a lot of crossing of paths with the COVID, but it's obviously a negative thing when things are going on in the home and we don't know.
Yeah, and so maybe it is access to technology right now, so you can see into the home, or some people are even going outside of the home and seeing people outside of the home. That might be something too, but that's more of an agency type of decision if you're able to do that. Then you can actually get eyes on the individual and see maybe if they're disheveled. You can see all sorts of stuff.
I know that right now I'm delivering Meals on Wheels, and I've gotten some calls to check, you know, because I do get to see people. People have asked me to check about certain individuals where they, you know, have had trouble getting in touch with them. So if there is somebody like that that's going into their home, to use that as a way to get some information.
Collateral information, I love it. It's amazing. Yeah, that's great. Great. Anyone else have any questions or hands raised for anything that we were able to address? I actually don't see any other hands raised. Sandra, did you have something, or did we? Yeah, go ahead.
Oh, Karen, I'm just wondering if you had a chance to answer all of the questions in the question pane yet.
Oh yeah, I've been chatting through them. A lot of people were saying that, talking about the complexity of an older adult related to medication, and offering some volunteer work. I didn't see any questions. Let's see. One was, I have a few older adults that they work with. Despite pharmaceutical interventions, they can't be free from the auditory and visual hallucinations. How common is this? Does it occur throughout the lifespan, and it is exclusive, or is it exclusive to the aging population? And so I do wonder if that individual may have something more serious going on related to mental health. So individuals can experience late life bipolar and late life schizophrenia. While these normally people will normally get these diagnoses at age 25. Some people at later adulthood will actually get these diagnoses. And so I'd recommend a mental health screening and potential intervention if that is the case for older adults. This may be specific to the pharmaceuticals though, in which we would have to speak to the primary care provider and to make sure that there's no interaction between the medications that they're taking. Oh, whoa, there's a lot more. Okay. I didn't see those. Okay, wait, there we go. Oh, a lot of people are responding to the REACH guidelines. That is awesome. Isolation is a challenge. Telephone connection is better than no connection. Thank you, Miss Mary. They're an aging service access point. We make telephone calls to service users in the home care, which is amazing. Some people are even sending out letters to people, snail mail for folks to reach out to individuals. Yeah, a lot of the programs are, are saying that, well, we can't provide them services because these are mental health services or substance use services because they don't have access to a computer or video conferencing. But just what Miss Mary is saying is that you can still access people through the telephone, and unfortunately for protective service workers, and they really generally do need to see the physical environment, and so that's a little bit different. And that may be a conversation with administration and leadership to go outside the person's home to check in if something is potentially going on, but not actually going into the home. Any other questions from folks? Great. Well, yeah, feel free to reach out to me or Jennifer. Jennifer will be sending out the curriculum slides and the REACH worksheet. I'm happy to have further discussions, and thanks to the Tufts Health Plan for allowing us to present this to folks, and also the Massachusetts Association for Mental Health. Now is a very trying time, and so we're glad that there's a lot of people out there who are looking to help some of the most vulnerable populations, the older adults that we work with. Jennifer, did you have anything to say before we sign off for folks?
I just would like to thank all of you again for being here. We are so admiring of the work that you're doing, especially now, and that you are finding time to join us today is an honor for us. So thank you so much for being here, and we wish you a great rest of the day.
Thank you.
Great. Thanks, everyone. Appreciate it. Take care. Thank you, Jennifer.